Right. I think we've got close to 60 people now, so I should probably get started now. So first of all, big welcome to everyone who's joined, and particular welcome to Tony Redmond, and of course Becky's husband, who's been able to join already. And hopefully, with luck and a fair wind, her mum will work out how to work Teams and join, and in-laws, who knows, anyway. Now, this gives me particular pleasure because Becky is one of those people who has actually made great progress in her career at Warwick. You know, I saw from her CV, she did a master's first, then went on to do a PhD here, which she received in 2012. And then she's actually progressed to the ranks and now is in a leadership position in the CTU. And she's works with a multidisciplinary team and actually tries to answer questions of importance to her particular discipline. And that is, so it's really pleasing to see that, you know, so, and a good inspiration to the people earlier in their careers who are aspiring to do similar things. So let me just also go through some housekeeping things in this strange format we have. So first of all, for things to work well, it'll be really helpful if you switch off your videos and audios. I will actually be muting everybody just before Becky starts because it really does improve the audio and make it good for all of us. Becky, you'll have to unmute yourself because I can't do that for you. So before you start speaking, not now, but you'll need to unmute yourself. And then we can listen to the lecture. At the end of the lecture, it'll be really nice if everybody unmutes their microphones and shows appreciation in the normal way. A great big cheer. So,
how's that?
that's very good, very good. That's excellent. You're good to go, Becky.
There would be an IT issue. Sorry, everyone, for that slight delay. I'm just building the tension. Thank you for your time. This is strange times, and I feel that I can't really start this presentation without mentioning COVID in particular. And it's made it quite a challenge as an academic doing presentations, as you've just witnessed. I spent 5 minutes trying to share my screen. But the picture that you can see on this slide is of me as an avatar. So a couple of weeks ago, I was invited to the Chartered Society of Physiotherapy to give a chat about research in orthopedics as a career option. And in preparation for this, I had to design an avatar, pick some clothes out for it, and then go into a virtual world that had beaches, speedboats, football pitches, and auditoriums. And on the day, I went into my auditorium and the virtual world glitched and I was kicked out and they wouldn't let me back in again. So I was hoping that this Teams format would be easier, but that start hasn't proved so. There's no speedboats or beaches that you guys can explore during this presentation. But I do promise to keep this quite a light-hearted presentation about who I am, where I've got to, and how I've got there, really. So I entitled this be a superwoman and not superwoman, because as Sadesh has kind of pointed out with some of the things on my CV, I do quite a lot. I'm a professor in a clinical trials unit. I'm an associate director in the same trials unit. I represent the university externally on different funding boards. I do a lot of mentorship. I've been a course director for an MSc course. And when I talk to people, they often assume I don't have time for anything else in my life. And I've literally seen jaws drop to the floor when I mentioned that I have 3 children. And these are my 3 children earlier this year whilst on an academic trip to Australia. And they're called Nicola, Jessica and Penny, and they're 7, 5 and 3. And when I mention that I have children, I normally get asked, so does your husband work full time? Surely you have somebody at home looking after the children. And I go, no, actually, I work full time and my husband works full time. And the next question I get is, well, you must have family nearby then. And again, the answer is no. I'm from Leeds originally in West Yorkshire, and my husband's also from Leeds originally in West Yorkshire. So we don't have any family nearby. Automatically leads people to believe that I must be some kind of superwoman. But I think this is where we need to be a little bit careful, because the definition of being a superwoman is somebody who can do lots of things successfully all at the same time. And that's not me. What I'm going to present to you over the next 40 minutes or so is lots of successful things, but they've happened over a career, and they haven't happened just because of me. They've happened because I've been part of a network of super people. So you don't just get in research one person who's truly a superhero. What you find is it's a lot more about putting that super person in the right place with the right people. And so a lot of my presentation is going to be about discussing who these super people have been throughout my life, really, and how they've influenced my career in research. So my academic career started out at a school in Leeds called Redillion. Now, if you're going to pick a future professor in a leading university, you wouldn't have gone there. And there's a few different reasons. The first one is that it wasn't a school that was known for its high academic achievement. Pupils did pass their GCSEs and A-levels and go on to university, but it was below the national average. And the second reason is that I wasn't from an academic family. So I'd come from a very large family. My dad's one of 5, my mum's one of 3. I've got a brother and sister and numerous cousins. But at that point in my life, I didn't know anybody who'd been to university, and I certainly didn't have any academic role models. It wasn't something that was, on my radar at any level. My dad was quite keen that I did go to university. It was something he was quite passionate about for me and my brother and sister, but it wasn't something that was standard. So me growing up, I had different types of role models and different ideas. Going to university wasn't my first port of call. I really love swimming, and this was one of my role models. So this guy is Adrian Morehouse. He's from Yorkshire, and he's an Olympic gold medalist in the 100 metres breaststroke. I was also pretty good at the 100 metres breaststroke, and I was going to be in a I had this role model, it was a viable career, and that's what I was going to do. And being from a sporting background taught me quite a lot. It taught me that if you put in the hard work, you will get results. But it also told me that if you put in the hard work, you don't always get the results that you want. And for me, I was a very good swimmer, but I wasn't good enough to be an Olympic swimmer. So I had to learn resilience, which I think is an important attribute as an academic. And I also had to look to other role models as to careers going forwards. So this is me back in the 90s with an Olympic gold medalist. working out that my career of being an Olympic swimmer wasn't quite going to work out, and I needed to reevaluate my options. So this wonderful woman is my mother, and at a certain point in her career, she worked at Pinderfields Hospital. Now, at Pinderfields Hospital, they ran an initiative entitled Take Your Daughter to Work Day. And my mum arranged for me over the years that she was there to spend a little bit of time with various different professionals. So I spent a little bit of time with some medics, I spent some time with some nurses, and then one day she introduced me to the physiotherapy department. And I was introduced to this physiotherapist in an outpatient gym. They were wearing trainers, navy joggers, a white polo shirt, and they spent all day in the gym rehabilitating patients after orthopedic procedures. So given that I was a slightly sport-obsessed individual who wasn't going to be an Olympic swimmer, I decided that a physiotherapist was probably the next best thing. I enjoyed wearing sports gear, and this guy got to do this for a job all day, every day. I then looked into being a physiotherapist and realised that to do that, I would need to go to university. And that was something that was a step into the unknown. I didn't know anybody who'd done that before within my family, but I went ahead anyway. And I did it. I went to university, and this is a picture of my mum and dad having spent what was a very cold evening that day in Middlesbrough. And they sat through hundreds of handshakes before then coming out to take this picture. Now, at that point, having just finished my degree as a physiotherapist, I didn't have a job lined up, and my dad really doesn't like to see me sat about doing nothing. Now, at the time, my dad was a gardener, and one of his clients was Dave Hancock, and he was the first team physiotherapist for Leeds United. So he asked Dave if I could have a bit of work experience that summer, not having a job lined up, and he certainly didn't want me in the house all summer. And Dave said, yep, that's fine, bring her along. So I went to Leeds United. Now, at that point in time, there was one person who I spent most of my summer with, which was Michael Bridges, and he's the chap in the bottom corner. Now, Michael Bridges was a striker for Leeds United. He was bought from Sunderland for around £5 million. He scored 21 goals in his first season. He had a bright future ahead of him. However, he tore his Achilles tendon a couple of years into his contract. It's a devastating injury and ultimately career-ending for a lot of sports people. So being the diligent person that I was, I thought, well, if I'm going to spend my summer holidays here at Leeds United, I best learn a little bit about Achilles tendon ruptures. And they're fascinating structures. So this is an Achilles tendon. So as you can see, they start off from a very small subunit called a tropocollagen, and these then form to make a microfibril, fibril, and so on until you end up with a tendon, which is surrounded in an epitenon and a fluid-filled paratenon. And these collagen fibres also are surrounded by a matrix ground substance, and this also helps with support and diffusion for nutrients. So this is how tendons get their strength, but it's not the whole story. We also have to consider the biomechanics of tendons. So this pink picture here shows that the alignment of the tendons is nice and parallel, which fits in with that hierarchical structure that I just showed you. And they're also what we call crimped, so you can see that they're all squashed up. Now, as you load a tendon, so as you put a muscle contraction through it, those collagen fibers start to straighten. So the graph on the right-hand side, you can see here that as you put stress through the tendon, the fibers straighten, and then it then goes through what you meet end of its physiological range, where you put so much stress through it that it just simply starts to break a little bit. You get this microscopic failure, and that's fine if you operate within that physical change, because you get that microscopic failure, but then the tendon repairs itself and you can go back and put more stress through it. If you put too much stress through your tendon, then you end up with a rupture, it just fails. We also know that tendons have viscoelastic properties, so we know that they respond to time and rate. And the easiest example I have of this is if you imagine hanging your bike up in the garage on a bungee cord. If you go back to that bike 6 months later, it'll be a bit closer to the ground, and that's because the bungee cord is lengthened. And it's not lengthened because the bike's got any heavier, it's lengthened because it's been under constant force time, and that's led to a process called creep. And tendons display these similar biomechanical properties. But it doesn't really answer the question, why does a Premiership striker in his 20s rupture his tendon? He did it during a football match. He was just running up and down the pitch, kicking balls, just like he's done a million times before. So he wasn't putting it under any undue stress. So why did this tendon fail? So we know that tendon ruptures are actually just the end stage of a disease process. So the slide on the left shows a tendon with those parallel arrangements, and the slide on the right shows an abnormal tendon. So you can just see that structure is just completely disorganized. We know when we look at this through an ultrasound, you can see an infiltration of blood vessels. We know clinically there are some people that don't feel anything and don't even know they've got abnormal tendons and continue playing their sports to a high level. And there are some people who do know they have abnormal tendons because they suffer with pain, they get thickening of the tendon and they get swelling. We don't yet fully understand why tendons become painful, and we refer to this as tendinopathy. It's thought to be multifactorial, so there's thought to be quite a few reasons why tendons become abnormal. So having spent my summer at Leeds United and looking into what a tendon was, why it becomes abnormal, I was then ready for the interesting part, which was, so how do we rehabilitate this footballer? How do we get him back onto the pitch? And this is what I found. I found quite a few textbooks that told me that rehabilitation needed to be progressive. You need to not do too much too soon, otherwise you will re-tear that healing tendon. But beyond that, there was absolutely no literature or clinical trials to guide practice. When I looked into the literature, I did find clinical trials that doctors had done to compare surgery to not doing surgery for tying up the two ends of the tendon. I found that doctors had done some research looking at different surgical procedures. And I also found that doctors had done some research looking at whether to put people in a plaster cast or a boot immediately after the tendon tearing. I didn't find any examples of evidence from physiotherapists or led by physiotherapists. So I was beginning to question what evidence-based rehab was and if it was applicable to me. So I did get a job after that summer. I got my first job at Harrogate and District Hospital, and I was kept on at Leeds United with their youth academy, so I worked there most evenings and weekends. And much like most physiotherapists, I spent the first couple of years doing my junior rotations, working across different departments. But I found myself getting increasingly dissatisfied with my job. And it was because I was being told to do things, but I didn't understand why I was being told to do them. A prime example was the orthopaedic ward, which did absolutely drive me nuts. So on the orthopaedic ward, you would have 20 patients who'd had a total knee replacement, but I would be asked to follow 5 different rehabilitation protocols for the same surgical procedure. And it wasn't because there was any evidence base for me to follow one or other rehab protocol. It was simply because that surgeon wanted to follow that rehab protocol and that surgeon wanted his patients to follow a different rehab protocol. There seemed to be no evidence base to what I was doing or why. I wanted to challenge it, but I couldn't because I didn't really understand what good research looked like or how it should be integrated into my practice and implemented. So I applied for my second job. I decided that I needed to get a greater understanding of research and what it was before I could effectively challenge. So there was a job at Warwick University for a research associate, so for somebody to consent patients into clinical trials and to also collect follow-up data. And I quite liked the look of this job because it was integrated with a partner NHS trust, the University Hospitals of Coventry and Warwickshire. And at that point, I was interviewed by an orthopaedic surgeon who asked me a little bit about my background and what I'd done. And I mentioned briefly that I worked at Leeds United. I then got a load of questions about football, which seemed rather odd at the time. But I just put that to one side. I thought I'd take this job. At the time, the same orthopaedic surgeon ran an MSc course. I thought I will do that MSc over 2 years. I'll develop my understanding in evidence-based practice, and then I'll go back to Yorkshire. I'll go back home. So that slightly odd surgeon turned out to be Professor Costa. And the questions about football were less surprising when I found out that he was a huge Liverpool supporter and was also a little bit football mad. So that's a picture of him in the top left corner delivering the MSc course. And along the sides, you may notice some of the other UHCW orthopaedic surgeons who also contributed to that MSc course. And in the middle, there's Jewel Atkin, who wasn't a doctor, and she wasn't male. So she taught me that research was, it could be done by people who were not the standard male orthopaedic surgeon. Now, that course was really important to me in my career development, because the way in which it was set up was that I learned about orthopaedic procedures and rehabilitation, but for everything we were taught, we then had a follow-on lesson with Professor Costa, which was about where's the evidence. We looked at the literature, and we didn't want to just see if there was any literature there. If there was some, great. But we would then pull it apart. We'd then do a critical appraisal so that we understood what good research looked like. So it wasn't just about finding articles to prove your point. It was about finding good articles to prove your point. One of the greatest quotes to have ever come out of this course was when I was involved in a lesson about validity, and we were talking about outcome measures. And more specifically, in a clinical trial, you have to have an outcome measure that will prove or disprove whether something works. And so we were having a discussion about when is something valid? How do you know it can measure the thing that you're wanting to measure? And an exasperated Professor Costa just said, right, let's forget about orthopedics. Think about love. Think about how would you measure love? How do you know if someone loves someone? And quick as a flash, somebody on the course said, well, that's really easy. The bigger the diamond ring, the more they love you. So that's one view on validity and outcome measures. And in the background to my, whilst I was doing my MSc course, I did drag somebody else down with me who did propose with an adequately sized diamond ring. So this is my husband, David, and he's kind of been there with me throughout doing my degree and my MSc. And I did drag him down on this premise of, I will do 2 years, I will do an MSc, and then I will go back. But unfortunately, I had been bitten by the research bug. And at that point, I had to ask him, could we stay for another 3 years whilst I did a PhD? He could see this was really important to me. And when I referred back to my earlier slide about being surrounded by a network of super people, I mean that in every sense, both personally and professionally, because you need both sides of that to be successful in this career. So I did. I went on to do my PhD. Now I convinced Versus Arthritis to give me £124,000, which is a huge sum of money, just to look at the Achilles tendon. So although I did spend that time with Leeds United and working with Michael Bridges, the Achilles tendon kind of came full circle for me, because it turns out that Professor Costa, who had worked with me on my MSc, had also done a PhD on the Achilles tendon, and there were still quite a few questions to ask. So what you can see here on this slide is a framework for developing interventions, because you can't just make up an intervention and then test it. You have to develop an intervention in a systematic way, and this is one of the ways in which you can do it. So my whole PhD was really based on that very first box, development. It was about identifying the evidence base. It was about developing theory for what might work and why, and then modelling those outcomes before then moving on through the stages to pilot that intervention in a clinical setting, and then finally evaluation and implementation. So this is what I did for my development work. So I did publish a systematic review on rehabilitation methods after an Achilles tendon rupture. To develop my theory, I ended up going to a gait analysis lab and looking at healthy participants under different conditions and using these pressure sensor maps to develop what might work and why. And alongside this, we ended up doing a little bit of work on outcome measures and validity. And if we did develop this intervention and we did want to evaluate it, we had to make sure that we had a good measure which would show success or failure of that intervention. So I did end up going into the murky waters of validity. So I did successfully gain my PhD, and I was supervised by Dr. Jewel Aitken, Professor Rebecca Costa and Professor Sally Lamb. And following my PhD, I applied to NIHR, and they had just launched, I think I was in the second round of their clinical academic stream. So I applied to be a clinical lecturer, and this was a 50% research funded post and a 50% clinical post. And I was at a real career crossroads at this point, because having just done a PhD, the expectation was that I would go into an academic job. I would get a job in the university and do research. And although the term clinical lecturers and clinical academic careers is very common and is accepted in amongst medical professions, it isn't for nurses and midwives and AHPs. And certainly when I finished my PhD and I approached the NHS partner, University Hospital Coventry in Warwickshire, about doing this, they were very enthusiastic. Unfortunately, the physiotherapy department were less enthusiastic, and I got a lot of questions around, well, why would we employ a clinical academic? What value do you bring? And they just couldn't quite get their head around it. But Kerry Jones, who's in the middle here, she was extremely supportive, and she said, look, Becky, just apply for it, see what happens. If you are awarded, we will make this work. And I think that just about sums up, Kerry, that if you come with a good proposal and it's innovative and it is going to improve patient care, then they will try to make it work. And I went through the process and I was awarded a clinical lectureship. So I was given another £150,000 just to look at the Achilles tendon, but this time to move into that feasibility strand. So we took the intervention that we developed as part of my PhD and we put it into clinical practice. So then during my postdoctoral years, I successfully completed that feasibility work and then moved on to a further fellowship with NIHR called a Career Development Fellowship. Now, during this time, I was supervised by three academic supervisors, Professor Tony Redman, Professor Martin Underwood and Professor Matt Costa, representing Leeds, Oxford and Warwick University. And this was really starting to grow my collaborations and networks. And I mentioned that in the last slide that I wasn't warmly welcomed at that point. I have to say things have changed now, but because careers were accepted within the medical field, they were quite happy to have me working with them. So Mr. Jonathan Young, who's up in that left top left corner, he took me on as my clinical line manager. Little did he know he'd be doing that for the next 10 years. So I just want to say thank you to Jonathan for doing that. So during these postdoctoral fellowships, obviously the Achilles tendon remained something that I was still very interested in. But alongside doing the work on how to rehabilitate somebody when the tendon is torn, we started to look a little bit more at what to do in those earlier stages of the disease process, so when the tendon's just a little bit painful. And we went to Versus Arthritis, and it was at that point I was awarded my first project grant of just under £500,000 to look at managing tendinopathy. In parallel to that, I was also doing some collaborative work with Monash University, and over to the right-hand side is a chap called Peter Malieris, and he was successful with a funding stream in Australia, again looking at tendinopathy in clinical trials, but looking at a different intervention to me, looking at something called high volume injections, and that work's still ongoing. And then sticking with the foot and ankle, because having developed such a good network of people to work with, I also started to develop some streams in ankle fracture management, which I'll talk about a little bit more now. So first of all, tendinopathy. So this really came about because the National Institute for Health and Care Excellence had published some guidance that basically said a very specific called autologous blood injections didn't have any evidence behind them, and we didn't know if they were safe, so they should only be used in the context of research. So I then went on and did a Cochrane review looking at injection therapies for Achilles tendinopathy. And it turns out that as a body of allied health professionals and doctors, we're injecting all sorts into Achilles tendons, and most of them have very little evidence. We then held a workshop with clinicians and patients. We went through the evidence. We agreed that there wasn't really an evidence base for much of what we were doing. But what we agreed was a priority list. What should the next thing we should be researching, and why? And we agreed that autologous blood injections was an area that was growing in popularity, and that we should either find out works or doesn't work. So this then led on to the Achilles tendinopathy management study, and this has recently finished. We've recruited all our patients, we've analysed, and in fact we have our final oversight meeting tomorrow. So I'm unable to give you the results of this, but just to give you a flavour of the type of thing that we do, we basically, anybody who came to hospital with a painful Achilles tendon that lasted longer than 3 months, which had changes that you could see on an ultrasound or MRI that I discussed earlier, met our eligibility criteria. We then randomised people by chance to either receive the platelet-rich plasma injection, which is basically blood taken from somebody's arm, spun in a centrifuge, and then injected back into their tendon, versus a placebo. And we then follow patients up at 3 and 6 months, collecting outcome data on how they've done. And that programme of work has taken around 5 years in total, with 3 years of that being recruitment. Inside my portfolio, a growing portfolio of trials in tendon rupture and tendon pain, I'd started to look a little bit at ankle fractures. So one of the benefits of being a clinical academic is that obviously you have your programme of research, but in the clinical environment, you're just quite happy to question a little bit more. So I was working alongside Mr. Young in Fracture Clinic, and we see a lot of ankle fractures. And it comes to my attention that some clinicians put them in plaster casts and some clinicians put them in boots. So I was quizzing him about this, just saying, you know, what do you want me to do in clinic? And he said, I don't know. I said, why don't we do some research in it? So we did. We applied to research patient benefits, and we got some feasibility funding. And then from there, we got funding to do the main trial. But this was a little bit different. So for this, it wasn't a project grant. This was a fellowship. And at the time, Professor Underwood was the CTU director. And I put forward this proposal to do a multi-centre clinical trial across 20 hospitals, recruiting 500 people under the envelope of a fellowship. And yeah, he simply said that can't be done. He said it's never been done. We've never costed for a full RCT. And we went back through all the NIHR fellowships, and no one had ever been awarded anywhere near £1 million. So it looked like we weren't going to go ahead with this. But then I spoke to a few more people, and we went, and one of those people was Tony Redmond, and we spoke to NIHR, and the feedback we got was, well, it hasn't been done, but that doesn't mean that we wouldn't do it. So with that feedback, we decided to press ahead. So AIR was really about comparing plaster cast to boots after an ankle fracture to see how quickly people can get back to their normal lives, basically. And I remember going to the interview for this fellowship. These fellowship interviews are quite intense. There was around 20 professors in a room sat in a U-shape with me at the front of it. And there was a professor of surgery who simply said to me, why would orthopedic surgeons nationally listen to you as a physiotherapist for doing this trial? She was basically saying, why would people recruit to your trial? Surely these people don't know you. You don't have the profile to deliver this. And I thought about that question for a moment. I thought, why would they listen to me? She's right, they don't know me, and I'm not an orthopedic surgeon. So why would I be able to deliver this? How can I give them that? How can I prove to them that we can do this? And then I just had this moment where I realised that this isn't about me. This isn't about whether I can deliver or not. This is about the trauma network. And what we had at that point was a track record of the trauma network delivering randomised clinical trials across the country. And that was my response. So how did we do? The trauma network responded. So the blue line there is what we had planned to do in terms of recruitment. So we had planned to recruit just over 400. But what we actually did was recruit 669. And this is purely down to the efforts of the trauma network and has very little to do with me and people knowing who I am. So this was a real testament to be able to say to NIHR, we can deliver these things under a fellowship. They are a great training vehicle, and the networks are there and they work. Unfortunately, just like the other trial, I can't give you any results because we've not got it published. But something I can give you results for is the Achilles tendon rupture work. So I kind of left the story at development and feasibility. We did make it to the third box of evaluation. So we applied to NIHR Health Technology Assessment to evaluate the interventions that have been developed. And this was led by Professor Matt Costa from the Oxford group in Tendons, and I was part of the team. And just to give you an idea of the scale of the work, there were 39 sites that took part. They screened just over 1,400 people with Achilles tendon ruptures, of which 1,000 were eligible. And we published it early this year in the Lancet, so we do have results. And we found that overall there's strong evidence that that a functional brace that you can remove provides similar outcomes to traditional plaster casting, which you can't take off. We found that the braces were safe and very likely to be cost effective to the NHS. But we also found that there's further research required for those later stages of rehabilitation. So there's still plenty of more work to do, and I'm still very heavily involved in Achilles tendon rupture research. So alongside all this portfolio of research, I've been quite active in growing networks and partnerships because it's very clear to me that this is the key to successful research. This is less about individual CIs and it's all about the networks. So for my most recent study called Artisan, which is looking at shoulder dislocations, we mandated that we'd have 2 PIs at each site, a surgeon and a physiotherapist. And the reason I did this was to try and grow the research culture amongst physiotherapists and to get them to step up into those PI roles that have traditionally been held by doctors. I'm also a co-research lead on a national network called the Association for Trauma and Orthopaedic Chartered Physiotherapists. I'm a national mentor for NIHR for people who are on the clinical academic programme. And I've been used as an example by NIHR in one of their themed reviews for developing clinical academic careers, because they acknowledge that they're not straightforward, they're not easy, we're still developing them, and they're still not normal in hospitals in the same way they are for medical professions. I've also begun to grow in, as Sadesh alluded to earlier, into management roles within the university. So as well as being chief investigator for my own programmes of research which sit within the theme of surgery and rehabilitation, I also work alongside Professor Perkins and all these other super people that are on this slide in delivering the overall strategy for the clinical trials unit. And I really enjoy this work because what I've come to realise is that this really does transform the lives of patients. It really does lead into that immediate patient benefit from delivering those clinical trials. And behind each chief investigator, there's the programming team, there's the quality assurance team, there's the trial operations. I really can't emphasise enough how many people are involved in the back room that you just don't see. So I'm going to end my presentation by reiterating that message of be a superwoman and not a superwoman. Surround yourself with super people, both professionally and personally. And just to really highlight what a super person my husband is, I mentioned earlier on that I went on an academic trip to Monash University in Australia. What I didn't mention was that I went out there on my own for a few weeks. And then he flew to Australia with 3 kids on his own and met up with me. So if that's not the definition of somebody who's super, I don't know what is. So thank you very much, everybody, for your time. That's been a little bit of an overview of some of the things that I've done and some of the fantastic people I've had the opportunity to work with and the networks that I've worked within. So thank you very much.
Thank you, Becky. If you could actually switch off the slide so we can see you again. Can I ask anyone to unmute this? Yeah.
Yay! Becky.
Right. So thank you very much for that brilliant lecture. There's a theme that runs through your lecture, and that is about being a role model. And I guess, and also about being a superwoman. But the secret is you surround yourself with super people, and that I can see how that helps with academic success. I'm not quite sure how it helps you become a super mom though, because unless your husband is also a superman and you can cope with 3 kids. Now,
yeah, it's a joint effort. I can see my mum's made it onto the call. I can see Diane.
I'm sure she'll be really proud. Normally, I usually have lunch with the family and guests. Of course, we can't do that these days. There is one bit I do at this stage normally, and that is to hand you the Warwick Medical School obelix to mark this occasion. So there you are. It's magically appeared at your house.
Yeah, thank you. It landed on my porch yesterday.
So really glad that you've been able to give this, because one thing you learn doing these during these leading lives lectures is you learn a little bit about that academic discipline, and we've learned a few things about Achilles, tendonitis, etc. But you also learn a bit about the person, and I think it's good to be able to hear your journey up to this point. And if seeing your CV before wasn't inspiring, hearing it all surely is inspiring for people on this Teams call. But hopefully more of whom will see it on the recorded version, when it goes out with the newsletter. Okay. Thank you very much, Becky, for that brilliant lecture, and thank you to all the guests who could make it. And thanks to all the people who've joined this call to celebrate Becky Kearney's inaugural lecture.
Thank you.
Now, I've got to go on, and I'm sure many others will, but do please stay on and chat with friends if you like, because I think once people leave, you'll be left with your team, I'm sure. Okay, bye.
Thanks, Sudesh. See you later. And thank you, everybody, for the messages that are popping up. I'll let you go and grab your lunches.